Hey guys, it's Reem Sabouni. I'm one of the physicians here at Houston Fertility Institute. Thank you so much, Shelby, for that really sweet introduction. Well, I'm really excited to be here with you tonight and excited to chat about a subject that's obviously near and dear to our hearts and kind of raise a little bit of awareness about infertility. So this is National Infertility Week. So I thought we can do a little fun presentation to talk about some high yield things, talk about little myth busters and go from there. But the most important and the most exciting part of this webinar for me is actually the questions that you submit. So there's two boxes open, a chat box and a question and answer box. And I look forward to seeing all the fun and exciting questions that y'all have. So let's go ahead and get rocking and rolling with our webinar event. So today we're going to spend some time talking about some myths, some common infertility myths, and then we'll basically then kind of go through what infertility is and kind of what the definition, what's the basic workup that you can expect if you get diagnosed with infertility, what are some treatment options, and then also what are some things that you can do to potentially enhance your journey and, lead to a better outcome without just using medication. And then also, what are some resources that we can tap into that may make a big difference for you and help you feel like you get the support that you need. So let's get going. So what are some common myths? So the first one is something that I see relatively commonly is that young couples do not experience infertility, and that is not correct. When we think about our natural fertility, most of the time, most of the people that we're seeing are actually in their 20s, 30s, and 40s. And so, we get a range of patients ranging from very young to slightly more mature, shall we say. So I think that infertility is something that definitely affects a lot of couples, and it doesn't matter if you're very young or older in age. Younger patients do, unfortunately, also have problems conceiving. The next one I commonly get is seeking care for in an infertility clinic means I have to do IVF. That is wrong. We offer a range of treatments, and actually part of the whole diagnostic workup is to see if alternatives to IVF, like inseminations and things like that, would be an option or could be an option for you. And so IVF is basically one type of treatment that we have, but we have a slew of treatments that we offer to help our couples dealing with infertility. What about fertility is hereditary? So I have patients that come in that say that, well, everybody in my family has no problems conceiving. So that means that that means that I must be fine. Well, unfortunately, we know that that's not a case. There's a lot of individual variation. So while we like to say that we get some good things from our family and maybe we avoid some bad things from our family, unfortunately, fertility is not hereditary. And sometimes there are some things that can happen in our lifetime that can affect our fertility. If you have one child, you don't have fertility issues. Well, unfortunately, a big portion of my patients are people that have a child or two children or three children, and they're still having issues with fertility to complete their family. So remember, it's not about necessarily having just the first child, but also completing your family so that you feel that your family is complete. And that's part of our job here at Houston Fertility Institute, is to make sure that we're helping to build your family. Finally, that infertility is a woman's problem. Unfortunately, it's not a women's problem. It's a couple problem. So we don't like to point fingers or blame anybody, but we know that 1/3 of infertility is male factor, 1/3 of infertility is female factor, and 1/3 is actually a combination of the two. So it's not about seeking blame. It's more about getting information and coming up with a treatment plan so we can get our good outcome. All right, so those are some of our common myths that we have. If y'all have any other myths, please include them in the question and answer or the chat. And that way we can assess some more good myths. I look forward to seeing what y'all have. So let's start off with defining infertility. So let's identify the boogeyman and demystify him a little bit. So according to the World Health Organization, which is, obviously an international organization, infertility is defined as a disease of the reproductive system, defined by a failure to achieve a clinical pregnancy after 12 months or more of regular unprotected sexual intercourse. Notice they didn't say about checking ovulation predictor kits or things like that. So that's an important thing to say. It's just unprotected intercourse, and it's 12 months. Now, while we say 12 months of regular unprotected intercourse is the definition of infertility, that doesn't mean that's you have to wait 12 months in order to start the workup. For women that are over the age of 35, and there might be other circumstances beyond that, it might be a better idea to start the workup after just 6 months of unprotected intercourse, because at that point we know time is of the essence, and we definitely don't want you spending time with lesser effective methods when there could be something more sinister in tow. So what is the general workup? Well, the general workup of infertility, if you think about it, really kind of boils down to four main things. So we look at the ovary, we look at the fallopian tubes, the uterus, and then for the male side, we have to look at the swimmers, okay? So we have to take a look at the sperm. That's also in conjunction with some hormones, looking at some reproductive hormones, that if those are out of whack, then sometimes we can have a subfertility, meaning it's a little bit harder for us to get pregnant naturally. So let's kind of dive through these a little bit more in detail. And let's start with a very important piece of blood work that you're going to hear a lot of infertility doctors kind of talk about. And that is a blood work called your AMH, or your anti-Mullerian hormone. Now, this is a really important hormone because remember, women, we're born with a set number of eggs we'll ever have in our life. And then over time, it's really depressing. We're steadily losing them. And so this hormone is a marker about how many eggs do we have left. Okay, so it's a really important hormone. It gives us some idea in terms of how much eggs we have remaining. Now, remember, your AMH is not a marker of your ability to get pregnant. Okay, it's just a marker of how many eggs you have left. So it kind of gives you a little idea of your quantity. Okay, but remember, in things, it's all about quantity and quality. And quality for eggs is more geared towards the age. So that's our little blood work that we're going to kind of focus on. And then let's talk about looking at the uterus and the fallopian tubes. Well, there's two main ways here at Houston Fertility Institute that we kind of do a workup for looking inside the uterus and making sure our fallopian tubes are nice and open. Because remember, you can have, killer sperm and awesome eggs, but if the tubes are blocked and they don't have the ability to meet, then you're not going to be able to get pregnant with traditional intercourse or even doing inseminations. So with the hysteroscopy, this is a procedure where you are comfortably asleep for about 5 to 10 minutes, and you take a small little camera that is smaller than a pen, and you insert it through the vagina in through the cervix, so there's no incisions anywhere, and you are essentially looking directly into the endometrial cavity, looking for any issues that may render a cavity less than pristine, okay? And if there's any issues that we see, then we can take care of them at the time of the procedure, because this is both diagnostic and therapeutic. Then we take a little tubal catheter, which is a little hollow tube, and put it against the opening of the fallopian tube. And then we flush contrast tube and take an x-ray of your abdomen, looking for that contrast to leak out, checking to see if your fallopian tubes are actually open. Okay, so that's like the first option, a hysteroscopy, tubal catheterization. You get a lot of good information from it. Another option is an HSG, or if you want the long term for it, it's a hysterosalpingogram. And so this is a similar type of procedure. It's good in terms of evaluating your tubal patency, and it gives you a good idea of the contours of the uterine cavity. Unfortunately, it's not as detailed in terms of saying if you have any intracavitary lesions like polyps or fibroids or something like that. So it's not as sensitive for that, but it's a good alternative just to make sure that the fallopian tubes are nice and open. So that's so these two are good ways of looking. You can choose either, or you don't have to do both, of looking at the uterus and the fallopian tube, the inside where pregnancy actually implants. Then for our gentlemen, we take a look at a semen analysis. So with a semen analysis, it's important to look at a few different parameters and what we think are important. So the first of all is looking at the total motile sperm, right? So we're trying to make sure that our total motile sperm, ideally for an insemination, would be above 10 million. Below 10 million, we tend to see a little drop off in our clinical pregnancy rates. So that's why 10 million is kind of like the standard that we strive for. So, one of the things to kind of keep in mind. The other thing that we look for is the motility. So out of all the sperm that you have, what is the percentage of them that are actually motile or making forward progress? If you ever have an opportunity to look at sperm under a microscope, it's actually quite hilarious because you have some that kind of swim in a circle and then you have some that swim backwards, and those are not the ones destined to make it. But we're wanting to look at that forward progressive sperm. So that's one of the other parameters that we look at. And the last one that was really pretty important is morphology. So morphology is looking at the overall shape of the sperm. So as you can see in the slide, sperm can have a lot of abnormal shapes. And so it's important to see that, that you at least have above the minimum threshold of normal appearing sperm in order to help in your ability to get pregnant. So after we do the basic workup, and then we kind of sit down and talk about, well, what did we find? What does it mean? And what are our next steps and treatment options available? Most commonly, here are some of the treatment options that we're going to go through. Okay, so I'm going to spend some time talking about some intrauterine inseminations. Then we'll take a little soiree into IVF, talk about pre-implantation genetic testing. And then I want to take some special time to dedicate it to same-sex relationships and single future parents, because y'all are a large portion of our population and the patients that come and see us. And I think that it's important that we spend some time and talk about how any treatments are a little bit different and how we can support you. So for intrauterine inseminations, essentially, we have different ovarian stimulation or protocols in which we can stimulate the ovaries to produce, 1, 2, or 3 dominant follicles. So that way that you have 1, 2, or 3 opportunities of pregnancy that month. And we do that with either oral medications, injectable medications, or a combination of the two. And then we trigger with a trigger shot to cause that final maturation of the egg and for it to actually release at a very specified time. And then we pair that with an insemination in which we basically take a small little thin catheter and in clinic with a speculum exam, we basically wash the sperm and then deposit just the motile sperm to the top of the uterus, kind of giving the sperm a good shortcut into to be able to greet the egg as it's getting ovulated. So that's one option. Another option is doing IVF. IVF is in vitro fertilization, and this is actually a relatively new technology. It's only been around for a little over 40 years. And with in vitro fertilization, what we do is we actually use injectable hormones. And we use these hormones for an average of about 10 days of stimulation. And the goal of that is, instead of us getting only 1, 2, or 3 eggs or follicles to grow, we're trying to get the whole group of follicles that you have that month to continue growing. So let's think about it this way. In a natural cycle, you have a group of eggs that have been with you since before you were born, and they've now decided to become responsive to hormones. And out of that group, you get the emergence of one dominant follicle and the rest of the follicles die off, hence why it's such an inefficient process. Well, in IVF, what we're trying to do is we're trying to actually stimulate and rescue all of these eggs. So instead of just one, we're actually rescuing the entire cohort or group. And so it's not stealing any eggs of your future or anything like that. It's basically saving the eggs that otherwise would have died in this cycle had they not been selected to be the dominant follicle. So once you basically have simulated and your eggs are nice and mature and your follicles are a great size, then you get triggered with a trigger shot. And instead of us depending upon you releasing the eggs, we actually want to be there to retrieve the eggs. So we actually undergo an egg retrieval, which is done under anesthesia. And we basically pick up the egg under ultrasound guidance with a needle as seen in step 2. And actually on this ultrasound image, you can see the needle guide right here as the needle is puncturing into the follicle, and it's basically kind of sucking out all the follicular fluid and the egg. The egg then gets fertilized and it grows out into an embryo. And I'm going to kind of show you that progression. It's really cool. And then once you have an embryo, then you prepare the uterus with with hormones, with estrogen, followed by estrogen and progesterone. And then you do an embryo transfer with the same transfer catheter that you would use for an insemination. But this time you deposit a special little visitor as your embryo transfer. And then 2 weeks later, you find out if you're pregnant or not. So this is our egg to embryo progression. So here we are starting off with an egg, and then this is a 2PN, so good fertilization after you inject the egg into the sperm. And then you can see it kind of multiplying. So usually around day 3, you're about an 8-cell stage, and then you start getting a blastocyst formation around day 5 and day 6. And so this is what a day 5 or day 6 blastocyst looks like. So here, right here, is your inner cell mass, which is ultimately what will become your baby. And out here is your trophectoderm, which is ultimately what will become your placenta. So one of the cool things that we do, and this is a really awesome technology, is we have the ability of doing pre-implantation genetic testing. So what does this mean? So essentially, one of our big concerns, especially as our patients get older, is, well, how can I tell if my embryo is chromosomally normal or not? And so this is one of the ways to do that. So essentially what you do is, this is your day 5 or day 6 embryo, and this is actually them biopsying that trophectoderm, which is ultimately what will become the placenta. Here's the inner cell mass, which is the baby that they're saying far away from. So they take about 9 to 12 cells and they send it off to a special genetics company. And then 2 weeks later, you find out if the embryo is chromosomally normal or abnormal. And you also have the added information of knowing if it's a boy or a girl. So that's really exciting because it does increase your, by being able to know whether your embryo is chromosomally normal or not, then you are able to increase your success rates per transfer. Because remember, if your embryo is abnormal, it's either not going to take or it's going to lead to a miscarriage. It can lower your miscarriage rates per transfer because remember, the number one cause of miscarriage is chromosomal abnormality. And then it also, you also happen to know the gender. So you can, if you have a little boy and have a little girl, you can choose which one you want to transfer first. Or, some couples even do this for gender selection because their family, they have 3 boys and they really want a girl. And then some families have little girls and they want a little boy. So this is a way to help kind of complete your family and not even really having an infertility. So that's a really fun, cool little technology that I think is just super neat. Now let's spend some time about third-party reproduction. So essentially, for same-sex relationships or single future parents, there's always the option of utilizing donor sperm and or donor eggs. With donor sperm, there's lots of national sperm banks that we can give you information about, and we can kind of help guide you through this process. In terms of donor eggs, same exact thing. We're also very fortunate here at Houston Fertility Institute to have our own egg bank as a courtesy for our patients because we want to make sure that we can help you build your family. And for some women, it's with the use of donor eggs that's necessary. And even for our same-sex male couples, we need to have donor eggs available for everyone. So one of the really cool and exciting things is that we have at Houston Fertility Institute a third-party reproduction department. So we have an entire department that's dedicated for patients who are utilizing either donor sperm, donor eggs, and or even gestational carriers. So gestational carriers are women who can carry a pregnancy for another woman because of the fact that, maybe there's a medical indication for that, or even for our same-sex male couples, they commonly utilize gestational carriers. So it's really cool that we have this department, because they work very closely with our clinical team and are great funds of knowledge and resources to help you if you need to utilize the donor sperm, donor egg, or even the gestational carrier services. Sometimes it can be kind of tricky to navigate, so it's cool to have them as a good resource and on your team. So now here's a really cool thing. So what can you do? So obviously, anything that you can do to optimize your health would obviously be a great starting point. And that can mean different things for different people. So in terms of optimizing your health, I mean, the whole concept behind it is if you take a healthy woman and put her into a pregnancy, you're more likely to have a healthy pregnancy, versus if you have a compromised woman, and she can be compromised for many different reasons, whether she's anemic, whether she has glucose intolerance and has a high hemoglobin A1C, or she's a diabetic or has high blood pressure. All these things, we want to make sure we try to optimize as much as possible to look at it as like the whole picture. So anything that you can do to optimize your health would really make a big gains for you. Also, a big thing that we, that we want to talk about is also modest weight reduction. So, obesity is something that is affecting this, this state and this nation, and it's one of the things that we're commonly dealing with. And so when we talk about a modest weight reduction, we're talking about even if it's as little as 5% of your body weight. We know that obesity is associated with doubling the amount of time that it could take to potentially conceive a pregnancy. So anything that you can do to try to cut that down or kind of shorten that gap, you might find good returns on it. Especially our patients that have anovulation, or they're not releasing an egg every month. A modest weight reduction, I'm thinking of you PCOS patients out there, might be really important in terms of helping you, maybe start regulating your cycles a little bit. So this is something that you can do that's not hormonal in treatment. So when people talk about weight reduction, they're talking about, well, what's the ideal diet? Well, I mean, I think it's about finding more of the best diet for you, and it's a little bit more individualized than that. So, I mean, I think if we want to talk about broad strokes, it's about reducing processed foods. We all know these are things that we need to do. Focusing on more whole foods, meaning like fruits, vegetables, things that are less processed. And even potentially considering a little bit of intermittent fasting. Now, remember, intermittent fasting may not be the best option for some patients. So it'd be a really good idea to talk to your doctor about what would be the best, depending on what your personal medical history is. But these are some just general ideas. But obviously, when it comes down to it, when we think about weight reduction, it's all about calories in, calories out. And while we like to think that exercise is super important, it plays less of a role in comparison to our diet. So I'll leave it at that. Now, supplements. So commonly supplements that we talk about, so DHEA and coenzyme Q10, these are great supplements that can help you in terms of if we're concerned about egg quality. So remember, with quality, that the only predictor we have about that is your age. Okay, so generally over the age of 35, I know they have to put a cutoff somewhere. So over the age of 35, you have a higher likelihood of chromosomal abnormalities in pregnancy. So, some of the things to think about if we're concerned about egg quality. Ovasitol is a supplement that's recommended for women with PCOS. So with PCOS, remember, it's a hormonal milieu problem. And so this is something that some of the literature supports can help kind of improve that hormonal milieu for patients that have PCOS. And then vitamin D, I see patients every day that have a vitamin D deficiency. A lot of people in Houston have a vitamin D deficiency. It's a function of us not really being outside. And a lot of that has to do with the fact that it's really hot. I mean, right now the weather's really nice, but most of the time it's pretty hot. And we're covered and we're in our car. So we're not really getting the vitamin D that we need. So a little bit of supplementation over the counter is great, but it's also a good idea to come in and see what your vitamin D level are and see how far off you are and make sure that we get you kind of repleted into the normal range. Exercise. So I'm a big advocate of exercise. I think exercise is really important, but for the right reasons. I think that they're important for stress management, and going through an infertility process is very stressful. It's a very hard time for a lot of our couples. And I think exercise can really give you that outlet that you may need in order to help cope with everything that's going on. So stress management, and it's also really good for your cardiovascular health. So little things about that. So there's also alternative medical things, including acupuncture. So acupuncture might be something that patients find helpful for anywhere from stress relief to improvements in your outcomes to if you have diminished ovarian reserve and you're trying to, use acupuncture as an adjuvant to see if you can potentially improve your response. So acupuncture does play a role, and also sleep, guys. Let's not forget sleep. Sleep's really important. So let's make sure that we're trying to get, the adequate amount of sleep that we need a night to help us rejuvenate and allow our bodies time to heal and to be kind to our bodies. So some resources that I want to leave you with are the Houston Fertility Facebook support group. So we actually have a support group dedicated for our patients. It's a great place where you can talk to women who are currently undergoing treatments and, can have somebody that you can kind of ping ideas off of, get resources, get that support that you need, someone that understands because they're going through the process simultaneously with you. So that's a good resource that we offer our patients. There's also national resources like Resolve. So Resolve is an awesome national resource. It's basically the National Infertility Association. They're awesome. If you have an opportunity to attend a meeting or something like that, you should. They're a wealth of information, and they were founded by women and men just like y'all. And then we also have in-house financial counselors. I think that's an important point because a lot of time with this fertility journey, a lot of people get concerned about costs, and they want to know about whether their insurance is going to cover it versus not cover it. And so a really good boon that we have for our patients is that we have in-house financial counselors so that they can talk to you so you can understand the financial component about this infertility and demystify it a little bit so that you can pursue the treatment that is right for you.